Radiotherapy is a huge part of how we treat cancer. But have you ever stopped to think about how a beam of energy actually kills a cancer cell? A lot of students find it tough to connect the physics of radiation with the biology of the cell. So in this explainer, we're going to build that bridge right from the ground up. And we'll do it by following the journey of a single photon.
This really is the central question, isn't it? How can we use something so powerful to destroy a tumor, but at the same time keep the patient safe? Well, the answer lies in understanding the very precise, very controlled journey of a tiny packet of energy, a photon, from the machine right into the heart of a cancer cell.
So to really get this, we're going to follow the life of one of these photons. We're going to trace its path from the exact moment it's created, through its interaction with the body, all the way to the final damage it inflicts on the cancer cell's DNA.
Okay, this journey really has three key stages. First, generation. Where in the world does this photon even come from? Second, tissue interaction. What happens when it hits the body? And finally, the most important part, cellular damage. How does it actually kill the cancer cell? Let's start at the beginning.
So, the photons we use in radiotherapy are just tiny packets of electromagnetic energy. They've got no mass, no charge, and we get them in two main ways. Either we create them as X-rays in machines called linear accelerators, or they're given off as gamma rays from the natural decay of radioactive stuff like cobalt-60.
Now this slide shows the single most important interaction that happens when a photon enters our tissue. It's called Compton scattering, and you can think of it like a game of cosmic billiards. The incoming photon, our cue ball, smashes into an electron in one of the atoms in the tissue. It knocks that electron right out of its orbit. This fast electron now carries the energy, and the original photon bounces off with less energy. This whole transfer is how radiation deposits its energy exactly where we want it.
Okay, so the energy has been delivered. We now have this fast electron zipping through the cell. The big question now is, how does this energy actually cause lethal damage? Well, turns out there are two main ways this can happen.
First, you've got direct action. This is pretty straightforward. The electron itself directly smashes into the DNA molecule and breaks it. This is the main way that heavy particle radiation, like neutrons, works. But for photons, the X-rays and gamma rays we use all the time, the number one mechanism, the real star of the show, is indirect action. See, our bodies are about 70% water. So that electron is much more likely to hit a water molecule, splitting it apart and creating these super unstable, super reactive molecules called free radicals.
And these free radicals, they are the real assassins here. You can think of them like tiny little grenades going off inside the cell. They don't travel far, but they violently react with and damage the most critical target we have, the DNA. By breaking those DNA strands, we stop the cancer cell from ever being able to divide and reproduce again, and that effectively kills its lineage.
So now that we've seen how a single photon does its job at the microscopic level, let's zoom out. How do we as clinicians use these ideas to design a treatment that actually works? This is where the fundamental principles of radiobiology come into play.
First up, a core law of physics. The inverse square law is incredibly important, especially for something called brachytherapy, where we place the radiation source right inside or next to the tumor. All it means is that the radiation dose drops off very fast as you move away from the source. So if you double the distance, you don't get half the dose, you get 1/4. This is amazing because it lets us blast the tumor with a lethal dose, while the dose to nearby healthy organs like the bladder and rectum falls off really quickly, keeping them safe.
This is another key concept you've got to understand. A single dose of radiation doesn't kill a fixed number of cells, like, say, 1,000,000 cells. No, it kills a fixed percentage, a fraction of whatever cells are there. So this is why we don't just give one massive dose. We use fractionation. We give many smaller doses over several weeks. This gives our normal, healthy tissues time to repair themselves between treatments, while we just keep chipping away at the tumor population.
Now this is extremely high yield. Oxygen is what we call a potent radiosensitizer. But why? Well, it's because oxygen makes the damage caused by those free radicals permanent. It essentially fixes the DNA breaks in place so the cell's repair machinery can't fix them. This is exactly why big, bulky tumors, which often have a core with very poor oxygen supply, we call that hypoxic, are so much harder to kill with radiation.
And finally, timing is everything.
A cell's vulnerability to radiation changes depending on where it is in its life cycle. It turns out cells are most sensitive during the M phase, mitosis, and the late G2 phase, which is right before they divide. This is a huge advantage for us because cancer cells are, by definition, dividing way more often than most of our normal cells. So they're statistically much more likely to be caught in one of these vulnerable phases when we deliver the radiation.
And just to show you what we use in the clinic, this table lists some of the key radioactive isotopes we use in gynecologic brachytherapy. You'll notice they all have different half-lives and are picked for very specific jobs, whether it's a high-dose rate treatment inside a cavity using cobalt-60 or maybe an implant right into the tissue with iridium-192. And here's what it looks like in practice. This is a classic brachytherapy setup for cervical cancer. You can see a device called a tandem placed in the uterus and these ovoids in the vagina. The radioactive sources are then loaded into these applicators. You can really see how this setup lets us deliver a super high, super targeted dose right to the cervix, perfectly using that inverse square law we talked about to spare the bladder in front and the rectum behind. It's really quite clever.
Okay, before we recap, let's just quickly clear up a few terms that students often get mixed up. Getting these straight is really crucial, not just for your exams, but for understanding what's happening in the clinic. Let's nail down these three. First, radiosensitivity versus radiocurability. They are not the same thing. A tumor's cells might be very sensitive and easy to kill, but if the tumor has already spread everywhere, it might not be curable with local radiation. Second, brachytherapy versus teletherapy. Brachy means close therapy. The source is inside the body. Tele means distant therapy. That's your standard external beam radiation. And finally, early versus late side effects. Early effects, like diarrhea, happen in tissues that divide quickly. Late effects, like fibrosis, show up months or even years later and are caused by damage to slower dividing tissues and their blood supply.
All right, let's bring it all home. We're going to consolidate everything into the most important high-yield points. If you only remember one slide from this whole explainer, make it this one. This is pure exam gold.
Here we go. The key mechanism for photons? Indirect action through free radicals from water. The primary physical interaction? Compton scattering. The key law that protects our healthy tissue? The inverse square law. The biological key? Oxygen is a massive radiosensitizer. Remember the OER. Our strategy is built on fractional cell kill, which lets normal tissue repair itself. And the target is most vulnerable in the M phase. Got it?
So what's the big takeaway from our photons journey? It's this. Radiotherapy is this beautiful, precise application of both physics and biology. We use photons to create those tiny chemical grenades inside cells, which go on to destroy the DNA of rapidly dividing cancer cells. And every single clinical principle we've talked about, from fractionation to applicator placement, is designed to tip the balance of that damage decisively against the tumor, while giving our healthy tissue every possible chance to recover.